All right, good morning. I'm going to go ahead and call this meeting to order. This is the PEBB board meeting for February 23rd, 2021. We did have to reschedule from the February 18th meeting due to the weather and the power outages that many of us experienced. I'm Kimberly Hendricks, your chair, and I'm going to go ahead and do a quick roll call and see who we have in attendance. Kate Nass.
Good morning, I'm here.
Good morning. Dana is absent. Kim Harmon.
Here.
Good morning. Sean Parkman.
Here.
Good morning. Mark Perlman.
Here.
Good morning, Mark. Saban Martin.
I'm here.
Good morning. Jeremy Vandehey.
Morning, I'm here.
Good morning, sir. Senator Betsy Johnson. Representative Andrea Salinas.
Hi everyone, my name is Miranda. I'm her new chief of staff. She has caucus in Florida this morning, so she'll be unable to join us. So I'm just kind of listening in this morning.
Well, welcome and thank you very much for letting us know.
Yeah, absolutely.
All right, so our first order of business is to have someone or to review the minutes, and if we have someone that would like to make a motion over the minutes, or if you need a moment to review them, please do so. It's from January 19th of 2021.
This is Siobhan. So I have reviewed the minutes. I had a question because I had a question about everyone in attendance because I thought Jeremy was there. So I just wanted to double check before I made a motion on the minutes. Jeremy, were you at the last meeting?
That's a really good question.
I think you were there, Jeremy.
Okay, there we go. Thanks,
Yeah.
Ellie.
Yeah.
Okay.
Blurring together a little bit.
Yeah, so I am happy to make a motion to approve the minutes and amend that Jeremy Vandehey attended the last meeting.
Thank you, Siobhan.
Thanks, Siobhan and Ollie, for knowing where I am better than I do, apparently.
Do I have a second?
Second.
Sean, thank you. Is there any question or comments regarding the motion to accept the minutes as amended? Okay, I'll go ahead and I guess I'll do roll call. I'm sorry, I just did roll call, but we'll do it again. Okay, those in favor of approving the minutes as amended, Kate?
Aye.
Kim?
Yes.
And then Sean made the second. Mark?
Aye.
Saban made the first. Jeremy?
Yes.
All right. Any opposed to the minutes? It looks like we had a total head count there. All right. Opposed. All right. The minutes will be amended and then posted on the website for folks to be able to see. All right. Next up. And sorry, I'll wait for Rose here. I'm trying not to get ahead of her.
Next up is the carriers for COVID.
Sorry, I didn't print. I was being paper conscious and I didn't print out the agenda. And so
That's okay. And it changed. So it's COVID first, and then we'll do Weight Watchers, WW.
Okay, perfect.
Okay.
So we'll have our first presenter, and I'm not sure exactly who was going to present first.
Kaiser should.
Oh, it's Kaiser.
Okay, wonderful. Well, good morning, and thank you for joining us.
Good
And they have no
morning.
slide.
Correct. Hi, this is Sapari. Thank you, Kimberly, very much for having us here today. We have a couple of presenters, or actually I have a couple of presenters with me today to give you an update on vaccines. And Dr. Katie Scharf is actually our lead infectious disease physician, and she's here today to give you some insights on, what is the latest on vaccines and safety and availability. And I also have Jennifer Stacy here with me to kind of talk about the vaccine distribution, and then I'll end with kind of some member resources. So with that, I'm going to turn it over to Dr. Scharf to kind of give you the update or kick us off.
Sure. Can you hear me okay?
Yes.
Yeah.
Hi there. I'm Katie Scharf, infectious disease physician for Northwest PERM, and I was asked to give a brief update on where we are with vaccines and what we know. And there's a lot of information, and I have, I think, about less than 5 minutes to discuss it. So I'll try and keep it brief. So right now, as I'm sure you've seen throughout the media, is that we are currently have 2 vaccines that have emergency use authorization to use. And that's the Pfizer and Moderna vaccines, which are a 2-dose series. We have been using those since mid-December. They are both mRNA vaccines. And just to kind of give a little brief information on that. So mRNA vaccines are not novel platforms. They've actually been around since the 90s, and there have been several decades of research looking at these vaccines for other diseases. And really what they do is they capitalize on our own immune response to provide protection. And what we have seen with these vaccines in the clinical trials, as well as this being borne out in real life data, both from the UK and Israel, is that they're highly effective. Vaccine efficacy of 95% seen in the clinical trials, and similar efficacy from real life data. And they protect against COVID-19, symptomatic disease, including severe illness. Other important information on these vaccines is their safety profile. So with these vaccines, both in the clinical trials and what we've seen in the US after administering over 54 million doses, is no true safety concern. So most common side effects are things that we would expect with other vaccines, such as muscle aches or pains at the site of vaccination, low-grade fevers, fatigue, just generalized muscle aches and pains or myalgia. So things that we'd see with other vaccines. We are closely monitoring some rare adverse allergic reactions that can occur with these vaccines, occurring anywhere between 2 to 5 cases per million doses administered, which is slightly higher than what we see with annual influenza vaccine, which is about 1 to 2 cases per million doses administered, but have very good safety protocols for managing that. And then in the interest of time, just to give you a brief update on the Johnson & Johnson vaccine, which is probably undergoing FDA approval, or excuse me, FDA review this Friday. And then hopefully ACIP will review the data after that. So this is not the same platform as the mRNA vaccine. It's an adenovirus vaccine, and it's a 1-dose series. And based on the clinical trials that we have of 44,000 participants, good vaccine efficacy. And so I guess one message I just want to put out there is you'll see vaccine efficacy of 72% for the US, in the literature. But if you actually look at the data, the vaccine was very good against preventing severe disease, so no hospitalizations or deaths with this vaccine. And so really, in terms of what we want it to do, which is to prevent hospitalizations and people dying from COVID, it does the job. And so, don't get hung up too much on the numbers. This vaccine effective at preventing hospitalization and death. I don't know how much time I have. I was going to just touch briefly on the variants. So as you're seeing probably a lot in the lay press, more and more information on variants coming. So, just to provide the information that having virus variants is to be expected. So viruses mutate over time to essentially increase their fitness or their ability to survive and transmit. And we see that with all viruses. And so as expected, the COVID-19 virus has also done that. And so there are 3 variants of concern that we're really watching closely. The B117, which is out of the UK, and then the South African and Brazilian variant as well. And I think a lot of concern about vaccine efficacy and the variants. And what we're seeing based on the clinical data is the current vaccines in use do offer protection against these variants. And, they offer that cushion where we'll still have adequate protection against the variants. So I think reassuring data from that standpoint. Other, highlights to hit home on. I guess one thing to be aware of is that the CDC just updated their guidelines on quarantine after vaccination. And if you are fully vaccinated and 2 weeks after your last dose of vaccination and asymptomatic, even if you have a high risk exposure to COVID-19, as long as you're asymptomatic and recently vaccinated, CDC is not requiring quarantine for those individuals. I know I have limited time, so I'm going to stop there and see if Jennifer or Sophie have other things to add.
That's great. Thanks, Dr. Scharf. Maybe I'll turn it over to Jennifer to give a quick update on the vaccine distribution, and then we'll circle back around if there are questions.
Sounds good. Thank you. So just a quick touch base on the vaccine distribution in Southwest Washington, Mid-Valley and Salem, and Lane County, where vaccine has been limited. However, we are vaccinating out of our local medical offices in each of those spaces as we receive vaccine. We are also partnering with various public health offices to both receive vaccine and to vaccinate patients that they send to us. And as supply becomes available, we'll continue to partner with other systems like Salem Health or our partners in Southwest Washington on distribution. Where the majority of the vaccine right now that we're giving is in the Portland metro area. That's where the supply is coming in for Multnomah County, Washington, Clackamas, and Columbia counties, where we are vaccinating out of the All for Oregon Convention Center Clinic and the OHSU Portland Airport drive-through clinic for mobility challenged individuals. Last week, we ramped up production to take care of the folks that had to be rescheduled because of the ice and snow that forced the clinic to close for 3 days. And each day last week, we vaccinated between 52 and 5,600 people a day. We are in the process of continuing to ramp up capacity at the Oregon Convention Center in anticipation of additional vaccine becoming available. One thing I would say is that we understand that vaccination sites like this are not the end all be all, and that we have equity issues we're working to address, as well as, different focuses on underserved groups, but we do think it is key to reaching herd immunity quickly to be able to safely and efficiently vaccinate thousands of people a day at these sites. That's how we will get through the majority of the community and then be able to address others. So we are working with many organizations to look at how we will address the inequities, including doing focused events. We're working to put together a Pacific Islander vaccine event at North Lancaster. I mentioned the OHSU site for the mobility challenged, and Kaiser Permanente Northwest was just recently approved under their federal pharmacy program. We're working to build that program, and we think that will be a key component to improving access to vulnerable populations. Finally, I'd say, just so you're aware, the vaccination data does have a lag as it comes in, up to 10 days in Oregon, about 30 days in Washington. But as of yesterday, we were showing that about 4,600 vaccinations had been given to PEBB members, and almost 1,700 had been fully vaccinated with both doses. And, as everyone knows, this is a kind of all hands on deck resource, moment. We've been shifting resources across the organization to support the vaccination efforts, leveraging retired physicians and nurses, getting support from the National Guard, group volunteers like the OEA and the Northwest Carpenters, as well as individual volunteers. But I'd also just say that for many of these people, this all hands on deck moment has been going on for over a year now. We're depending on the same people like Dr. Scharf, like many of our clinicians that were there in the beginning fighting against the pandemic and have been there the whole time. And so as we continue to build this vaccination system and strategy, we will also be looking at how we move this to sustainability. I think that's all I have,
Okay,
Sapari,
thanks.
if there's...
Yeah, thanks, Jennifer. And I just wanted to close with, a lot of things are happening, a lot of things are changing every day. And so wanted to assure you that, we're continuing to keep our members updated as to what's going on. We're sending out almost weekly updates to our members with respect to updates on the COVID pandemic. We are sending emails and doing webinars for our groups and our consultants to make sure that they're aware of the status. And in fact, if I could put a brief plug in today, that at 12:30 this afternoon, Dr. Scharf and actually Dr. Imelda Deconis will actually be presenting an update or a webinar on vaccine distributions. And we had offered a webinar a few weeks ago, and it was met with great enthusiasm because during that webinar, we actually had over 100 questions come in as we were presenting. So this is, we know that there's a need, we know that there's a lot of questions, so we will continue to do that. And then I wanted to say that, in addition to our webinars, we have resources available on our website, as do the other plans, and it's set in a way that it's before the firewall, so anyone can go in and access data or information on the pandemic. And then lastly, just wanted to state that, the support that we ask of you is to continue to direct members to the Oregon Health Authority website, which is a great website for members to, schedule appointments and answer many questions, our websites. And then at the present time, as you know, demand is currently outweighing the availability. So we just ask for your continued patience and understanding, and thank you for that. So that's all I have, or all we have. Kimberly, is there any questions for us?
This is Siobhan. I just had a quick question. When you reported the numbers that 4,600 PEB members had received at least one dose and 1,700 had received both doses, that's for all PEB members, not just Kaiser. Is that right?
That is Kaiser members.
Okay.
Just to, sorry, I was a little unclear. There's 4,600 vaccinations given. So 2,900 people have gotten their first dose and 1,700 have gotten both doses.
Okay, thanks for that.
Yes.
Perfect. All right, and I was able to attend the webinar last week. I'm going to see about this week's, and thank you so much, Kaiser Permanente. All right, on to MODA, and I've got Dr. Singh and Erica should be on.
Good morning, Robin Singh, MODA Health. I'd like to provide an update on COVID-19. Coronavirus cases are now declining globally, nationally, and within most US states. Around 45 states are seeing a decline, including what used to be major hotspots such as California and Texas. Similarly, in Oregon, we're observing a significant decline in cases for the last couple of weeks. This is likely due to a combination of growing immunity from vaccines, prior infection, as well as testing and isolation and general preventative measures. There could also be other factors that are under investigation. Despite this, the virus continues to mutate, and these variant strains are being observed all over the world, including some that have likely originated within the US. Globally, we have over 110 million cases with around 2.5 million deaths. Nationally, over 28 million cases, almost a third of the world's cases, over 500,000 deaths. In Oregon, over 150,000 cases and around 2,100 deaths. Yesterday, OHA reported 324 new cases with 0 deaths. For Oregon, most counties, around 25, are still deemed extreme or high risk, and precautions should continue. In terms of vaccinations in Oregon, around 800,000 doses have been administered to at least 500,000 people. Around 12% of the population has been vaccinated, which is similar to the national average. Here we've completed the earlier phases of vaccination and moved this week to all persons aged 70 years and older. The PEBB members data breakdown, these approximate numbers year to date, COVID-19 claims, so active test member count, 3,795, active test count, 5,269, antibody test member count, 274, the antibody test count is 282, the case count was 264, ER count 34, hospitalized was 12, ICU 5, with 1 fatality. In terms of vaccination numbers, vaccinated member count 36, first dose count 33, second dose 3, both dose, that's for the Pfizer vaccine. Moderna 66, 66 and 0, around $2,665 paid out there. Average cost per vaccine $26. Testing costs are $504,000 approximately, with treatment costs about $614,000 approximately. There's likely underreporting due to reasons discussed previously, and there is a delay in the data as well.
Great, thank you, Dr. Singh.
Sorry.
Oh, sorry.
A little bit more, if I may. In terms of treatments, only remdesivir, an antiviral, has been approved for the treatment of COVID-19. The expert US panel develops NIH treatment guidelines, and there are a number of other drugs that have received emergency use authorization. Given, however, that there are limited proven therapeutic options against SARS-CoV-2, the mainstay for prevention of further deaths is continued protective safety measures, testing and isolation, and vaccines. We heard about Pfizer and Moderna, that those vaccine rollouts continue. Vaccine distribution has improved across the country, more funds, resources, and across Oregon, as we heard. There are new short-term setbacks due to the cold weather last week affecting supplies across the country, but these should restore quickly. Additionally, we're hopeful within the next week or so, as we heard from our colleagues, that Johnson & Johnson single-dose vaccine may receive emergency authorization, and that has more regular storage requirements. The biggest concern is potentially these new variants, the UK, South Africa, Brazil, and several new strains detected within the US. For example, in Southern California, there are some reports of higher transmissibility, hospitalization, and deaths from some of these strains. These concerns are leading to vaccine manufacturers to be considering working on new versions of the vaccines that can address multiple strains. That being said, these vaccines are highly effective and life-saving. A UK study published yesterday showed results for the Pfizer vaccine. The risk of being infected was reduced by 70% after a single dose and by 85% after a second dose. Overall hospitalization and death is reduced by 75% after a single dose of the vaccine. There's a variant there of significant concern, the Kent variant, which is spreading rapidly. This vaccine remained highly effective against that strain too. The overall goal here is to reduce death rates in those vaccinated and also to reach herd immunity, protecting those who do not have access to vaccines, which is most of the world, or are not receiving them at the same rate. Significant racial disparities exist, those in whom it's contraindicated in children, amongst others. Of course, herd immunity may also bring an end to the pandemic for everyone, though there is concern that the virus could persist at low levels in society. Thank you.
Great, thank you, Dr. Singh. And just really quick, want to just provide an update on communications we have available to our members around COVID. We recently sent out a colorful communication through the mail to all of our PEBB members talking about the safety of the vaccines and just giving an explanation of how the vaccines were developed and the quicker process. We also have that posted on our website. We have a PEBB-specific MODA site and then also a PEBB-specific COVID site. So we have all of the information on safety. We have links that link people to the Oregon Health Authority to get additional information about vaccines and the eligibility levels, as well as information about their benefits. In addition to that, one of the links that we have on our sites is a link to SiriusMD, which is our new telehealth app that we just launched 1/1 for PEBB members. And this is no member cost share, and members can text, talk, or video with a doctor 24/7 So it gives them a lot of convenience if and when they have questions. And thank you very much. Any questions for Moda? Great. Well, thank you guys.
Thank you so much, Dr. Singh, for joining us. Thank you, Erica.
Thank you for having us.
All right, next up is Providence. And I assume Cash will make introductions.
Yes. Hi. Good morning, Kimberly. How are you?
I am good. I got power.
Yeah, wonderful. Nice. That's good for everyone that has power now. So with me today, so I'm Cash Spencer. I'm the manager of our self-insured line of business within Providence, and I manage the relationship between PEBB and Providence. With me today, I have, I know the agenda says Dr. Gluckman was going to join us, but he is not. So we do have one quick switch up. Helen Noonan-Harnsberger, who is our vice president of our pharmacy department, will be here to talk to us about the vaccines. And then also with us is Greg Dietzman, who is our vice president of healthcare services. So with that, I'll turn it over to Helen and Greg to give us a quick update, and then I'll just close out with what we've been doing as far as communications go.
Okay, hi, this is Helen Noonan-Harnsberger. Can you hear me okay?
Yes.
Okay, great. Thank you so much. So I'm going to focus my comments today and the comments from Providence really on our vaccine deployment strategy through the health plan in conjunction with our health system, Providence St. Joseph Health, throughout Oregon, in all the counties that we have PEBB members in. And we do have a health plan deployment strategy that is aligned with our health system and certainly with the All for Oregon group in our tri-county areas that you've heard of and I'm sure read about it as well. But we're also making sure that we have all the right tools and things available in our organization at PHP to make sure that we can respond to all the questions. So we have established a series of work streams. We have a communication work stream that really focuses on our web messaging, which is updated routinely and is really the front door into getting into the OHA site for scheduling and for good information, both from Providence St. Joseph Health and a variety of webinars that are posted on our system site for COVID-19, but also then information about how to get vaccinated, which of course is the biggest question. At this point, we have not sent out a paper flyer. We plan to do that at a later date, but right now the focus really is on using electronic communication, and certainly the news is certainly keeping that information out there. One of the other areas we've really focused on is our member-facing services. All of our departments who talk to members have been trained on vaccine deployment and how to get patients access to vaccine, with also urging patients and helping people understand the scheduling process in their county. It's really, as you know, highly variable depending on the county, with the tri-county area being really focused on the convention center process. But in the other counties, it's certainly more direct, usually coordinated through the license, through the local public health authority. And so that is, I think for many members, been a nice introduction to public health entities that they really didn't know who they were or how they worked. In addition, there are some smaller quote unquote mass vaccination clinics in some of the moderate sized communities. But we're making sure that the calls we're getting are being directed appropriately to help really ease the way of members. We also have been focused on data analytics and making sure that we understand who's vaccinated for the PEBB population. Currently, about 10%, 10.7% of the PEBB membership with Providence has received a first dose. Specifically, 5,100 PEBB choice members received a first dose. About 5,000 PEBB statewide members have received a first dose, for a total of 10,175 doses administered. Of the people who've received their first dose, 4,400 of them have completed the series. So of course, as you know, vaccine is limited. but we are tracking that. We're getting data on a daily basis to help really support our members in that regard. And just real briefly, the other focus we have is really on our homebound members, and we do have homebound members that are part of the PEBB membership and other members with unique medical needs by making sure that we're using our case management department coupled with work through our health system where we're working to identify that population and approach vaccinating them in their homes through a home approach using EMTs. So that work is progressing really well. I just came off a call on that. And so we're working on that for all of our members, of course, and certainly any PEBB members that are impacted in that regard as well. We've also evaluated in certain lines of business the need for non-emergency medical transport. That's not currently an offering of the PEBB plan. It's certainly something that if you think there's a need, we certainly can look to offer that. But I just wanted to mention that in case that is something that you've heard is an issue, access and being able to get to a vaccination. And then there's specific work going on with the local public health authorities and the counties with regard to reaching the BIPOC communities and really making sure we have a focus on health equity. And I think that as we work through the process of vaccine distribution and get more vaccine, we will be able to work with the local public health authorities to get that out there to those communities in different ways. And then finally, PHP as part of Providence St. Joseph Health is really working like many of the folks in healthcare to really volunteer and help support at these clinics that we are a part of within our communities. And that's one of the focuses that we've made as part of our commitment to both the overall mission of the organization, but just to be a good community partner for all our communities. It's a tough time for everyone. And as you heard earlier, there are many people that have been doing this for a long time, and we're just another set of volunteers. We certainly have nurses and pharmacists that are vaccinating in these clinics, as well as people helping with various other pieces like preparing vaccines and in some cases just being a runner to be of assistance to help. So that's kind of our whole approach to vaccine deployment and how the health plan is supporting and working alongside with our health system to really facilitate deployment to all of our members, but really to all of our communities since it's a community effort. That's all I have for today.
Thank you so much, Helen.
Hi, Greg. Did you have anything to add to what Helen just said?
Yeah, just quickly, on just total cases that we've had come through for PEBB, we've had 49 COVID cases. We don't have any in the inpatient setting today. In addition to that, we have been actively working to outreach to those members that are at risk and working with them through our care management programs. In addition to that, through our collective platform, we have been doing a specific outreach to those that present to the emergency department with COVID symptoms. They may be positive for COVID or may just be presenting with COVID-like symptoms, and we're doing follow-up after the ED to help navigate any needs for those members, questions, and provide information and or answer questions around testing and vaccination as well. So just wanted to add that piece of information for the group too. So that's it, Cash.
Perfect, thank you. And just to quickly close it out, I know we're over time. We are, like Helen said, we haven't yet sent out a direct mailer to members, but we are keeping our website updated with information. So at providencehealthplan.com, there's information on how you can get access to the vaccine and the list of priorities, and then also some common answers to questions that people have about the vaccine. And then also as part of the Providence St. Joseph's Health information stream, we have the coronavirus.providence.org site that includes information on testing and treatment, and as well as getting information on vaccines, and then also the status of the number of vaccines that our hospital systems across the country have actually deployed. So there's always information out online about our efforts. And with that, are there any questions for Providence?
Thank you so much, Cash, and thank you, Providence. All right, so now we are going to move on from our vaccine updates, and now we're going to go to WW Annual Report, and we have Ashley Brown here, and I think Nicole is joining her.
Yes, hello and welcome. Thank you so much for having us. We actually have myself, Ashley here, Nicole, and then my other colleague, Kim, who manages alongside with the Kerbo program.
Oh, thank you.
Yeah, thank you all for having us. And I'll actually share my screen here. I'm a visual person. Can you guys see my deck here?
Yes.
Great. So one thing that I wanted to add before diving into the program, despite the very challenging year.
Ashley, I'm sorry, I think they're still seeing my screen. So let me take my screen down. Oh no, maybe they are seeing yours. Hold on. Let's try it. Okay, now try yours.
Okay.
And okay, now they're seeing your screen.
Okay, perfect. Thank you for helping me out there. Before I dive into the numbers, I wanted just to call out a few things that we have done alongside working with all the carriers for PEBB and the program, bringing a little bit of normalcy, I'll say, to the very challenging 2020 year that we had. And with WW, many of you probably think of us as a weight loss program. And at the crux of what we are, that is what we can deliver for results. But WW is so much more than that. And in 2020, with all of the things going on, the silver lining that we learned is more about what our members need. So when you think of our program in regards to what we offer, we're more than weight loss. We have 4 main pillars to the program, which revolve around mindfulness, which, as we all know, is a key component to success in all areas of our life and really learning how to be resilient and adapting to changes. Our other pillar of the program is, as we all kind of can relate to for WW, is food. And then we have physical activity. And then the 4th component that we recently added in November of 2020 is sleep. So we have 4 main pillars to really bring to life an entire robust wellness program that, if your goal is to lose weight, these components will help you get there. But we've really created an atmosphere and a culture for folks to come together that really want to move towards a really healthy lifestyle. So with that, the report I'll be sharing with you today will dive into 2 types of results. We'll talk about the adult population, so programming for folks that are 18 and older. And then I'll pass over to my colleague, Kim, to talk about some of our results for the adolescent population and for the PEBB group, that is ages 10 through 17. So here's a quick snapshot about what we saw for the PEBB population. And I think another great reminder is that 2020 marks the very first year. We've had a partnership for over 10 years, but we actually made a lot of changes. And thank you to all of you to help make the decision to shift the PEBB program over to our new platform, which allows us to really dig in deeper to some of the results I'm able to share with you today. So for net pounds lost for 2020, we saw over 17,000 pounds. As far as new members, and new members does mean brand new to the program in terms of into this platform, and we saw 7,610 members. That was a 5% increase from Q3, because we do review these results with the PEBB team on a quarterly basis along with the carriers. And for the population size that we're measuring against for 2020, that 7,000 is 7% of your eligible population for adults. Now, take that now into what's the average active members. And again, just a little bit of a data dictionary here. When I talk about average active members, that's the number of people who are actively in the program in some shape and form utilizing that. So that takes into account any cancellations that we have, et cetera. So over the course of 2020, the average was 6,263. That was another 5% increase from Q3, which ended the year at 6% of your eligible population. But it's one thing to get people into the door and into the program, but what I do want to talk about a little bit is the actual results in terms of once they're in the door, what did we see? So I'll jump to that here in a moment, but taking a look at member tenure. Now, a couple things happen here. We're on a new platform, so that the number that we see here, 10 months, that's what we saw for this year one of the program. We very well know that while we had some new members come into the program, there are some members who have been a participant for many years before that. So we'll continue to measure that member tenure as we continue our partnership. So switching gears here to give you guys a little bit of insight into some of the results that we saw, we look at 3% of weight loss or higher in terms of marking into what we've seen for progress. So you had over 2,000 members meet 3% of weight loss or greater. And that is a 6% increase from Q3. So we've seen consistent progress for your members. And when we take that statistic compared to the number of average active members, that equates to 34% of your average active members who hit a significant milestone. A couple of other key points I wanted to share with you all for results is the fact that when you think about positive shift in BMIs, we had a 14% increase in folks into the healthy BMI, and we had a 7% decrease of members in the obese 3 category. And on the next slide, I'll actually dive into that a little bit more just to show you more of that movement. But before I do that, a couple of other highlights I wanted to share was 18% of new signups in 2020 were spouses and domestic partners. And then we have a program mix here. So for the program that we have available to your folks, they have a choice of how they want to interact with the program. They can choose just to have the digital option. So 58% of your PEBB members are choosing that route, whereas 42% are choosing the workshop. And I want to take a moment here to talk about some shifts that we made. As we all know, March of last year, our whole entire world shifted into this virtual world. And we actually then created the ability for your PEBB members to attend virtually in an exclusive workshop so that they could have access along with their other peers that they were having access with prior. Because we did used to host over 100 in-person workshops in your locations. So when that came to a halt, we wanted to make sure that we were meeting members where they felt safe and to be able to provide to them the community that they really needed on their wellness journey. And then a few more stats here, 54% of your population. We have this entity within our program that's called Wellness Wins. It's a way to award people wins along the way for the behavior change that we know leads to healthier lifestyles. And so your population is definitely active in that in terms of utilizing those key components. I'm not going to talk about Kerbo. I'll let Kim do the honors there. But the last part I wanted to share with you all to do a deeper dive into the BMI shifts is giving you a much further deep dive into what these numbers showed for 2020. So what this does is it maps out, we do take in the year of 2020, so that reporting period, we map out people who had 2 weigh-ins during the reporting period, and we compare their very first weigh-in to their last, and then we map them out to share, did they either maintain their BMI classification or did they shift? So when we were able to look at that for the PEBB population, we had 19% of your population who either stayed in the healthy BMI category or improved their BMI. And we had 77% of your population maintain. And I think we can all attribute maintaining your BMI can be quite a feat alone, and then put in the layer of a pandemic. There's also a few shifts here that I wanted to share with you all today as well. We had 10 members move from obese 1 to healthy, which is a huge achievement. We had 13 of your members who moved from obese 2 to overweight. And then we had 15 of your members move from obese 3 to obese 1. So we look at all that data together, that's 96% of your population who either improved or maintained their BMI. And I'll pause there if there's any questions for me on some of the results for your adult population before I hand it over to my colleague, Kim.
This is Kimberly. I just want to go on record to say that just the fact that our members were able to be somewhat healthy during a pandemic and to not let the stress of this pandemic affect their lives and keep on track, I think is something that we need to, I wish that I knew who each individual, I'd write them notes to tell them how much I appreciate and applaud their good work during a pandemic, that's for sure.
Absolutely.
And just to continue on what Kimberly was getting at, is there any comparative data with the previous years where we could really draw some conclusions that members have become healthier with the pandemic and teleworking?
Yeah,
Mhm.
Unfortunately, we do with all of our other clients, but you were not on the platform where we could pull this data, which was one of the #1 reasons we wanted to get you onto our new platform, to not only make the member sign up process much easier and streamlined, we wanted to be able to have a benchmark in a place. So this is our benchmark to be able to compare this going forward. I wish that we had this for your populations, we just don't.
Okay, thank you.
Nicole, is there anything else that you would add for the adult population results that we're seeing here? She's probably on mute. Okay. All right, well, I am actually going to hand it over to Kim to give you some insights into what we saw for the Kerbal population.
Thank you, Ashley. I'm excited to share with you all the results from when we first launched with PEBB in January of 2020. Kerbo, just as overview, is a 3-month program. And over this past year, we have saw 155 enrollments. Of these, 141 were unique individuals. And to give more clarity into that statement, since PEBB so generously offers renewals to their members, there were 14 of those 155 enrollments were renewals. So 4 participants had enrolled for a total of 3 times for a total of 9 months of coaching. So they had 2 additional 3-month sessions, and 6 members had enrolled twice. So they had a total of 6 months of coaching. We really see that when members engage with us long, it really does create a sustainable, lasting change. Next slide, thanks, Ashley. And this slide paints the picture of what engagement looked like and who was actually participating. So as you can see, of those members that enrolled, 68% fell into the obese or overweight BMI percentile category, which is what we see for Kerbo's book of business. We typically do have a pretty strong engagement of participants who have a normal BMI percentile. And this just shows us that members are looking for opportunities to eat healthy and engage in healthier habits, both through exercise and diet, regardless of what their BMI percentile category is. And this is a really strong engagement of tracking and messaging with coaches, which shows what the impact is of our program. Next slide, please. The participation of the members was really good and much higher than we typically see, with a 90% of those individuals who engage in the program reducing or maintaining their BMI percentile. Now you can see the number who actually reduce their BMI percentile is lower, but that's not concerning because with kids, adolescents, we do see that as long as they're maintaining their BMI percentile, because they're growing taller at the same time that they might be gaining weight or maintaining weight, that is also progress. Those who were participating in the program had an average number of 12 coaching sessions, which is also very strong. And the average BMI percentile point reduction is 3.8. Next slide, please. here is a testimonial, which I think speaks just absolutely volumes to the impact of our program. And Aubrey speaks specifically about the impact that our coach had. And it really is our coaches that lead our members through the process of their either weight maintaining, healthy living journey. We are encouraging members over time to increase their green light fruits and vegetables and to reduce their red light foods. Our coaches are always meeting individuals where they are, giving them creative solutions for exercise so that they do actually enjoy their exercise, because that's what makes it sustainable over time. Next slide, please. So I just wanted also to address a little bit about the impact that COVID has had on your members as well. Our coaches spoke a lot about the fact that their direct relationship with families during this time had a huge impact on their coaching experience of the members. So we know that kids and teens were struggling with weight gain. They were really, the proximity to kitchens made eating and snacking much more challenging. We were all seeking comfort foods, struggling with exercise, both because of motivation, but also accessibility of our normal exercise routines. And just the lack of routine and boundaries made the year very challenging for kids and teens especially. And our coaches were really able to support their members on their personalized journey, providing suggestions and supporting them in key issues such as self-care and exercise and including even their sleep. Many members were anxious, and the extra support of the individualized coaching made a big difference. So I will pause there and see if anybody has any specific questions about the CERBO program and the outcomes that we saw this year. Well, thank you, everyone.
So I just wanted to add, this is Kimberly, and Nicole was having microphone issues, and she just wanted to go on record to say that she thinks that the weight loss performance is especially impressive, given the challenging year that we had had. Also, we know that some of our members have been members for many years, so seeing the continued success on the program is remarkable. So she apologizes for her audio problems, but I just felt it was important that we go ahead and note Nicole was trying desperately to talk to us. Thank you.
Thank you.
So I have a follow-up question. So one of the things, you know, that the board heard pretty loud and clear when we first were exploring the CERBO program was, you know, concerns around, you know, mental health, self-harm, you know, like that sort of business around teens, eating disorders, etc. And that, you know, there were concerns that were raised to the board about, you know, focusing on weight control and positive and eating habits, etc., could potentially further any of those. So I'm wondering, you know, and we talked about, you know, the research that went into the whole thing. So I'm not asking about to go over that again, but I'm wondering, just having now experience with our members, if there were any of those, you know, I think that we talked about having a sort of safety trigger, like if there's, if it's clear that someone has an eating disorder, they do not stay in the program, that, you know, they get referred somewhere else. I'm wondering if that you had any experiences with that, or any other insights or direct experiences with any of those concerns that were raised at the board.
So this is Kim again from CERBO, and thank you for bringing up that question, because I know that was something that was very thoroughly vetted and discussed at length. And we saw nothing like that within our program this year. There were no members that triggered any safety concerns. We have a very thorough process of oversight as high up as our master coach who oversees all feedback, and including in the survey results that came back from members, from PEB members who participated in CURBO, we heard nothing negative, and there were no safety triggers that were initiated as a result of inappropriate use of the program.
Yeah, and so just for the record, we were ready to detect those, and we didn't detect any.
Correct. Absolutely.
Okay.
I think it's worth also noting that if we were to detect them, we would definitely, Kim has a process in place to alert me, and then to also just let the PEB team know that, you know, we did identify X, Y, and Z. This is what our course of action was taken. So that would also be a part of our commitment to PEB as well.
Thank you. All right, any other questions for WW? Okay, well, we're a little behind, but I think we'll be fine. Thank you all so much for joining us. And now we will go on to renewal responses, round 1, and Nick Albert will lead the team.
Good morning, everyone. And Mitchell Nigro from our team will also be joining me. So let me share my screen here. Okay. Just confirming everyone can see that?
Yes.
Great, thank you. Okay, so 1 week delayed from when we should have been talking about these, but just given everything that happened weather-wise, we're glad to even have this conversation to begin with. So good to be talking with everyone today. This is the round 1 renewal presentation. So as you all are aware, we go through multiple stages of the renewal work, back and forth with your carrier partners, updating financial projections and whatnot. So this is the round 1 response to our questions. What we'll be going through today is financial overview. So how the plans ended up faring with as far as budget goes for 2020. How the composite rate is looking preliminarily for 2022, and then we'll get into the medical and non-medical renewal responses. There is only one decision for you all to make today, but that doesn't mean you can stop paying attention after that decision is made. We expect full engagement throughout. So just noting again, guiding principles. We have worked with all of you to develop these over the past 12 to 24 months. And so this is sort of our frame of reference for everything we do within the renewal space, and sort of our guiding principles and our lens for how we make decisions. So nothing has changed on this slide, but obviously what is new now are the health equity strategic pillars that we've been developing over the past few months. So now that we have this new sort of operating lens to work within to ensure that that the changes we're looking at, or the programs we're looking at for the upcoming year, align with the goals of the stakeholders and align with the needs of some of the priority populations that we've outlined through our health equity work that I know Michael Garrett has been involved with. So with that sort of additional lens, we focus now on the 2022 renewals and how those are shaping up. But first, so let's talk about COVID. So we had your three medical carriers talk about their updates to COVID. So we had one follow-up. So in the January board meeting, we discussed some of the utilization patterns we had been seeing as a result of COVID. We showed that there were sharp decreases in newly diagnosed patients for diabetes, asthma, hypertension, and also lower screening rates for some of the types of cancers. So obviously the fear from that is members were not able to get screened for these various conditions. They weren't able to get screened for, cancer, for instance. And so obviously then, the fear is the progression of those disease states or cancer is getting worse, and they weren't able to detect it early. So what we did in round one, we asked each of the medical carriers what actions they were taking to ensure members are receiving their normal preventive care and their preventive examinations. So you have the responses on the screen, but essentially for both Providence, MODA, and Kaiser, they emphasized the need for, or the use of virtual care. Kaiser in particular, I think it's well known that virtual care is a staple within their integrated delivery system. So that continued. They obviously have, primary care services, even specialty, consultations via telehealth. For both Providence and MODA, they both conducted outreach via telephone and mailers and other materials. And this sort of began after the initial sort of springtime shutdown that we all experienced. So for Providence in particular, those mailers started going out in the May timeframe. I think, or excuse me, MODA, those mailers went out in the May timeframe. Providence, I think, had a similar timeframe. Providence in particular, they do have the Providence virtual care option, and I know MODA has virtual care options through OHSU as well. So they were emphasizing those availability and options for members. For Providence, pediatric immunization mailers were mailed out to emphasize the importance of sticking to vaccination schedules for children. I think that's one of the issues that we've raised a few times is outside of just normal adult screening rates for various conditions, making sure children continue to stay on the appropriate vaccination path for all the normal vaccinations. So Providence in particular mailed out some material related to that. Erica touched on it when she mentioned the MODA 360 program. So as part of that program, there are virtual care options through Cirrus MD, which is a text-based primary care. There's also virtual behavioral health options through a vendor called Maru. And then Livongo for members with type 2 diabetes or actually just diabetes in general helps out with some of the virtual care related to diabetes and getting supplies needed for testing and maintenance of that disease. So what that helped to do is theoretically close some of the gaps in care that existed. For Kaiser, they actually restricted some of the child checkups to those who were under 2 years old, but they did create an option, which I thought was interesting, where medical assistant was able to do immunization schedules. So instead of members waiting in line for nurse treatment in the nurse treatment room, they could actually just go directly to the medical assistant to be able to get vaccinated to avoid those kind of wait lines. So I think needless to say, each of your carriers recognized that there possibly was going to be an issue with this, and outreach was conducted on PEBB's behalf to some of these targeted populations. The other item related to COVID that we wanted to bring up was the member cost share. So this is where we actually will need board action on this particular topic. So we asked each of your carriers to provide the latest guidance on waiving cost sharing for not only the testing component, but also the treatment of COVID-19. For Providence, testing cost shares are actually completely waived until the governor's public health emergency has ended. MODA does not actually currently have an end date on testing. So on the testing front, and same with Kaiser for that matter, on the testing front, we are okay on that. So until the emergency period ends, each of your carriers is going to continue to cover the COVID-related testing costs on behalf of PEBB's members. The treatment costs are where we actually need make a decision. And I guess technically it doesn't have to be at this meeting, but the treatment cost sharing for both of your self-insured plans is waived until March 31st. And so we'd like to make a sort of a call to action to possibly extend that. For Kaiser, both testing and treatment is waived. Member cost share is waived for both of those until the end of the month following when the national public health emergency ends. So the current emergency has been extended until April 21st, which means Kaiser is continuing to cover testing and treatment up until April 30th. So it ends the month end following when the emergency ends. Our recommendation, so Mercer's recommendation, would actually be to align that sort of guidance to the self-funded plans to continue covering treatment until at least the public health emergency ends. This way, all three vendors would be aligned, and also we wouldn't have to seek reapproval at monthly board meetings or bi-monthly or whatever that looks like. So that would be our recommendation, to align the three and to continue covering testing and treatment until at least the public health emergency ends. So any comments or questions?
Ollie, what did you want to do here? Did you want a motion?
Yeah, that would be great if the board's ready to move forward on this.
This is Siobhan. I will make a motion that we accept Mercer's recommendation. It's in line with how we've approached the treatment and vaccination. The treatment and the testing throughout COVID. So I just make a motion that we accept the recommendation as written.
Kim Harmon, I second.
Thank you. Any questions?
This is Sean. I'll just add a comment or speak to the motion that this seems like a fairly straightforward decision to me. I mean, we're still in a public health emergency. We are taking emergency actions to continue to respond to a pandemic. So from my point of view, I support the motion, and it feels like a natural action that the board would take in continuing response to this emergency.
Thank you, Sean. I'll do a quick roll call again for or oppose the motion as written. I think you can all see it on the screen, and if you can, I'll be happy to read it. Do I need to read it out loud since we're recorded? Are we recording video and audio?
Yes, that's correct, Kimberly.
Okay, so that it can be seen. So roll call, Kate Nass.
Aye.
Thank you. Kim is the second. Sean Parkman.
Yes.
Mark Perlman.
Yes.
Saban is the first. Jeremy, are you back yet, Jeremy? No. Okay. Okay. Any opposed? Okay, looks like we will, the motion is to align the cost share for treatment until the end of the month following the end of the national public health emergency, and align with Kaiser's approach, and will allow all three carriers to continue waiving cost share without continued board approval. Is that correct? Looks like that motion carried. All right, thank you.
We didn't realize, Kimberly, that would be such a mouthful, but you navigated that flawlessly. So okay, great, thank you. All right, so let's get into the actual renewals. So the first section here deals with the financials. The second, then we'll start getting into the carrier responses and whatnot. So the financial overview. So we want to set a baseline for all of you. So what we have on the next 5 slides are how the self-insured plans finished the year. as far as experience versus budget. So this is information that we send on a monthly basis to Ali and PEBB staff within OHA. But oftentimes it doesn't quite make its way to the board. But given that we do 2022 projections based on 2020 claims data, we figured it would be helpful for you all to have sort of a baseline understanding of where 2020 finished the year as far as claims versus where we expected them, where we expected the budget to fall. So each of these slides is sort of formatted in a similar way. We have the monthly expenses on the bottom row. We have the actual expenses on the left axis, and then on the right axis we have the plan's loss ratio for a given month. So essentially, when we budget, we budget for 100% loss ratio, right? When we set a premium rate, we expect the claims plus the admin fees that you pay to your carriers to be 100%. So when anything under when claims come in lower than we expect, that's when the loss ratio ends up being lower than 100%. And then on some months, if we come over budget, that's when we get a loss ratio above 100%. So each of these next slides kind of is, again, formatted the same way. The green represents the claims costs. So members actually going to the providers, seeking care, incurring claims. The purple represents the administrative fees or the fixed costs that you pay to your vendors. So these are the admin fees, essentially, that you pay to Providence Moda, and then the VSP and Delta Dental. And then the blue line is the loss ratio. So we put the loss ratio in there just as a point of reference for how these costs essentially align to where we thought they would be. So the blue line shows that, for instance, in April for statewide, costs came in at about 53% of where we would have expected them to be for April. And you'll notice across these next 5 slides, the dip in claims in April, even March, April, May timeframe. And then for each of these, the spike up once care resumed in sort of the early summer timeframe, in that July through August timeframe. Over on the right-hand side is some just point of reference statistics. So we kind of have a frame of reference when we're talking about each of these plans. We have the average number of subscribers. So for statewide, that's the amount of employees on average that were enrolled in the plan. So about 18,000 people. The full year loss ratio ended the year at about 85%. So for statewide, we ran 15% under budget, essentially, where we projected that statewide to end up. And then the cost component. So we have the claims make up obviously the majority of the cost for all these plans at $293 million, and then the fixed costs were about $21 million. And then finally, I think we've talked about the surplus in regards to the risk-based capital reporting due to COVID, and thankfully due to the fact that PEBB wasn't exposed as much as some of our other clients and other organizations throughout the country as far as COVID cases and diagnoses. The deferred care more than offset the cost of the COVID treatment. So for all of these plans, you're going to see a rather large surplus number. For statewide in particular, that 85% loss ratio basically attributed about $57 million worth of surplus for the 2020 plan year. So these two kind of go hand in hand. The loss ratio and the surplus go hand in hand together. So with that, again, PEBB statewide ended the year at about 85%. For choice, it actually ended up slightly higher. Choice ended up at about 88% loss ratio for the 2020 plan year. Choice actually is the highest level of enrollment across all I guess 4 of your plans at 19,000 people are enrolled in the choice plan. The total surplus for choice was about 38 million. So statewide definitely drove the larger surplus out of the 2 Providence options. And you can actually see yeah, go ahead.
Yeah, Nick, I just had a question just on the self-insured experience. I know that this year is an anomaly given COVID, and whether it would be helpful to also see what the claims were in 2019, so we can compare those to the claims in 2020 for the self-insured plans and get a sense of, what was the trend in a more normal year.
Yeah, absolutely. We can follow up with that. On average, Siobhan, they were about 5 to 10% lower across your plans compared to a normal year, but we can include that.
Thanks.
Yeah, certainly we wouldn't expect the amount of surplus that we gained in 2020 in a normal year, but that's a helpful data point, so we'll include that. On the MOTA side of things, so MOTA actually, you'll notice the dip for April and May was actually less than statewide and choice. So for MOTA, the loss ratio only dipped to about 50 or 62%, whereas both the Providence plans went down into the 50s. That said, you'll notice the MOTA never actually, sort of resurfaced past that 100%, like some of like Choice did, for instance, in a few months. So care overall, the premiums outweighed the claims and fixed expenses throughout the entire year for MOTA. MOTA has about 6,100 employees, average employees, and the total surplus was about 19 million for the MOTA plans. And then switching over to the dental side, this one for me as an actuary is interesting to look at, just because you see the April loss ratio, which is just really something I've never seen. March, April, and May, excuse me, you can see there are hardly any claims, especially in that April timeframe, at a 14% loss ratio. Once the dental offices were able to admit folks and resume their practice, that's when we saw the spike in the summer months. My guess, since dental is sort of an every 6-month type activity, we're going to see higher claims here in Q1 of 2021 as we look at experience, just because people getting their cleanings done in the summer are likely going to be getting one time frame. So my guess is the loss ratio or in this early part of the year will actually be a little bit higher, and it'll again tail off in the springtime. But overall, surplus for MOTA dental was about 8.3 million. Care continued to actually, so we saw the spike in the summer, and then it actually did trail off throughout the rest of the year. And then finally, vision. So vision had a similar experience as the dental side of things. So in April, we saw a 23% loss ratio, and in May, we saw a 60% loss ratio, sort of in that April-May timeframe. Vision actually ended the year at a high loss ratio at that 110%. You can see most of the care was incurred in January and the December timeframes. So again, just keeping this as a reference as we start talking about 2022 projections. Okay, so the composite rate. So last year, for 2021, we actually ended at a 0.8% increase to the composite rate. If you recall, we had projected a composite increase of 1.6% last year, but the board made a motion. I think there was some discussion about whether to do a 1.6% increase or to do just a flat 0% and essentially just buy down the entire composite increase. So we landed in the middle. So that's where you see this kind of odd funding assessment that we had to put in here. We had to basically just put in the funding assessment that make it work to get to a 0.8% increase to the composite rate. For 2022, our preliminary projection is looking at a 2.3% increase to the composite rate. So this is obviously below the 3.4% limitation, and which means we do have a buffer. So we have about $11.5 million buffer projected for 2022 preliminarily. And again, this uses 2020 claims data. So what we do on the back end is actually we're adjusting the claims data upwards because we know that 2020 is not a normal year. So we take that into account and essentially make adjustments to the underlying data to get us up to where we would think it would be. But that said, you know, the plans finished under budget even regardless. So even with the COVID adjustment to bring them back up to where we would expect them to be, they still finished under budget. And so that's where, you know, we're still falling below the 3.4% limitation. And then just finally on slide 14 sort of outlines the summary of the different coverages and where each of one of them is projecting. So we've ordered the premium impact by magnitude here. So statewide and choice obviously have the highest level of premium between all the plans that feed into the composite rate. So for statewide, we're projecting a 0.9% increase to the overall accrual rate at this point. Choice is a 4.3% increase, and that sort of makes intuitive sense just because choice had a higher loss ratio than statewide did for this past year. So they, you know, choice is getting a slightly higher increase. On this front, so you see the admin increase. So we've put the preliminary admin fee increase that each of your vendors is proposing for the 2022 plan year. So Providence is proposing a 3.5% increase to the statewide fee and a 3.4% increase to the choice fee. Going down, MODA is actually proposing a 2.9% increase to their fee, and Delta Dental, or MODA, is proposing a 1.5% for the admin fee on the dental plan. Over here, though, obviously this is what we kind of all care about because the admin fee feeds into the underlying projection. All of that is sort of built into this overall accrual rate increase. So overall, Kaiser's proposing a 2.7%, and MODA actually we're projecting that plan to be actually a decrease for this upcoming year. At least, again, all of this is preliminary, but as of this point, we're projecting a decrease. So overall, 2.3%.
And Nick, I just had a question here too, just around the admin fee increases and wanting to better understand them, because I thought in the January board meeting, we had a discussion about how some of our admin fees are higher than for other plans. So I just think digging more into that and why we have these increases would be helpful for us.
Yes, I completely agree. And it was on Mercer's radar before. Yes. So these, yeah, Siobhan, I should just note that these are preliminary. So in the round 3, we usually request best and final. And during that time, well, in between that time too, we want to better understand why those fees are increasing, especially given your point about the fees already being higher than what we see as benchmarks. So with that said, I will stop talking at least momentarily and let Mitch get into some of this.
Yeah, thanks, Nick. So the next section, we're going to look back at some historical things. So looking at what was done in 2019 for the 2020 plan year. And then the following slide is 2021 or 2020, what we did in 2020, looking for 2021. Really hard to think about years, especially now. So on this slide over there on the left, you'll see kind of the prior plan changes that were added for 2020. So expanding alternative care to include massage therapy on Choice, MODA, and Kaiser. And then as well as varicose vein coverage. And then on MODA, we implemented this pharmacy benefit optimization, which takes select infused medications and moves it to the pharmacy benefit. So overall savings for that program was about $360,000 based off 16 unique PEBB members. And then kind of going back to those first 2 bullet points, we kind of split them out, looking at each plan and how they changed within the year. So looking at massage therapy, you can see here on statewide, it was a bit of a 28% decrease. So something to note though, like as Nick was showing on those experience reports, some of these utilization metrics can be a little bit skewed because of COVID. But here in the middle, we have outlined them. And then on that massage therapy in choice, it says 333 were in paid claims. PHP actually provided, it was about 800 members with about 2,500 claim counts in 2020. And then down in the middle, looking at alternative care, you can see that choice had an increase, and then while MODA had a decrease for the increase there. And then underneath, you'll see varicose veins. The self-funded plans had about 634 in paid claims, which is a little bit more than what was projected on the cost increase back in 2019, which was about 500,000. So yeah, like I said, this is just kind of an overview of the items that were explored in 2019 and implemented for 2020. There's really no board action items needed right now, but we'll just continue to monitor these and keep a close eye. And then on the next slide, or if there's any other questions on that one, these are looking at items that we implemented for 2021 last year. So these were items that were approved at the last board meeting in spring. And so you can see the first couple lines are the medical. So viscose supplementation, which is basically a shot in your knee, which kind of we took away. And then specialty light on the MODA plans, which is coverage for specialty drugs limited to a 30-day supply. And then the real time benefits check built into the EMR systems. And then the implementation of MODA 360, which is more like a concierge type of service. And then the Optum ED analyzer, which helps with emergency department upcoding on the Providence plans. So overall, medical was about $200,000 worth of savings, and then $700,000 worth of enhancements on dental, which you can see we're removing those basic and major waiting services, and then the orthodontia waiting period. And then on life and disability with the standard, we increased that benefit max from 5 to 10,000. So there at the bottom, you can kind of see the total projected impact was about $950,000, which was an increase. And then above that, there are 3 items that were reviewed, but ultimately not accepted by the board. So increasing the alternative care benefit maximum, and then increasing vision hardware on Kaiser, and then keeping the 12-month orthodontia period. So that wraps up that section, unless you guys had any other questions on that.
I'll just say on the alternative care benefit, I think we had some member feedback that by adding massage therapy, we should subsequently increase the benefit maximum for alternative care. But quite frankly, the data, as Mitch showed, just doesn't support it. At this point anyways, there's not a lot of members reaching that maximum threshold at this point. So as Mitch said, we'll continue to monitor the utilization with those alternative care benefits, but at this point, we don't feel that it needs an increase to the maximum. Okay, so now we'll talk a little bit about the administrative fee overview. So Siobhan, I think this gets into some actual details about where within the admin fees are increasing. But again, we're following up with carriers on sort of the logistics of these. So Providence overall is proposing a 3.5% increase to the statewide, 3.4% admin fee increase for the choice plan. This table outlines the choice and statewide admin fees between 2020 and proposed 2022 by the different components that Providence breaks out the fee increase in, or the fees by. I've called out 2 distinct changes for 2022 that should be noted. So the first one is regarding these network access fees. So actually effective June 1st of this year, so June 1st, 2021, Providence actually has a new agreement with Cigna and Clear Health for their out of area and out of network claims. We are currently working on evaluating the financial impact of this change, both from, obviously financial to see if there's any benefit, but also from a member perspective to see if there's any sort of disruption. On that front, you'll see the network access fees increasing. So for statewide, it goes from 6.9 to 10.13, and from choice, it goes from $9.47 to $11.02. I know Mitch works on a client that has much higher out of state utilization than what PEBB has. And that client in particular was showed some significant savings for moving to this new arrangement with Cigna. It remains to be seen, though, what the savings will be for PEBB. And I know Cash is working with her team to provide those savings estimates for us. Providence is essentially moving from the First Choice First Health network over to this new Cigna and Clear Health partnership.
So Nick, just so I understand what you're saying that Providence believes that there will be savings associated with the increased admin fees. So, and if that's the case, will that be built into the overall calculation?
Yes. Yes. Okay. So what we'll do is assume the admin fee that you see here, but if there are savings to be had, we'll price those into the actual underwriting itself. At this point, again, we haven't received anything, and I know, again, Providence is working on that, so it'll be priced in by the time we get to the final, decision points. But at this point, nothing has been assumed yet within the rates. The other piece is the Behavioral Health Administration. So Providence has insourced their Behavioral Health Administration. So they had a prior agreement with Optum, and you can see that Optum charged a separate PEPM for their services. So statewide, for instance, was being charged $4.23 for the 2021 plan year. That goes away. But you'll see that the fee is now sort of baked into the underlying medical administration. So you can see that the jump on statewide, for instance, of $21.74 up to $24.35. And likewise, on the choice plan, you see a jump in the base administration fee. And that's really being driven by the fact that Behavioral Health Administration is being removed from Optum, and Providence is building their own behavioral health network that they're going to support internally, which requires the increase to their baseline administrative fee. And part of what we're doing actually on the Mercer side is working with Providence to evaluate their behavioral health readiness, essentially. So that'll be coming in Q3 likely of this year, just to do almost an overview of ensuring members are getting the access and the care that they need in the switch from Optum prior to Providence's built-in system. Okay.
Yep. So on the next slide, we're looking at standard contract changes within the Providence plans. So kind of that table outlines all of them, but kind of going through them. The first one is osteopathic manipulation. So this kind of deals with more of a treatment for patient muscles and joints using techniques that include stretching, gentle pressure, and resistance. So in the explanation there, it's kind of a lot, but essentially what Providence has offered forward is separating the office visit from the facility. So instead of having one payment, a member would therefore have two. And so we kind of look at that last bullet. There were 249,000 claims submitted on behalf of 597 members. So quite a bit of people have been utilizing this benefit. And then kind of over in the right is Mercer's recommendation, and we're recommending declining this as it can get kind of confusing when there's quite a bit of members already using this service, and now you're changing it from instead of 1 payment to 2 payments. And then underneath that one is pain management. So this would, Providence is proposing to move pain management from the physical therapy benefit, which has a visit limitation, to be covered as an outpatient service. And so Mercer is recommending that you accept this change because it's little cost impact, and it's actually a benefit enhancement for members because it's removing that limitation. And then the third one is applied behavioral analysis, which removes the exclusion around neurofeedback. And then again, similar with the other two, we recommend that you accept this change as it enhances benefits. And especially with this one, it lowers compliance risk because it has to do with mental health parity laws. So meaning mental health should be treated the same as physical health. And then the fourth one is coverage for wigs for drug-induced alopecia. So this is pertaining to cancer patients. So typically the drugs for cancer make patients lose their hair. So this would then cover treatment for wigs. And again, we recommend you accept this change, similar to the other ones, as very little cost impact. The next one down is biofeedback, which again, the first bullet kind of describes what it is. It's a mind-body technique that involves using visual and auditory feedback to gain control over involuntary bodily functions. Right now, there's a visit limitation at 10 per lifetime. And then that third bullet down shows only 1 member has kind of gone past that 10 visits. And there was no members in 2020. Our recommendation says TBD, but we expect any savings to limit that to be minimal. And since it's a benefit, it makes the benefits leaner. We recommend not implementing this. And then the second to last one is EBICOR, and I know that this has been looked at year over year. And so what it is it's kind of a gatekeeper for outpatient rehab services. And over there on the right, so after speaking with Providence, it's kind of determined maybe we delay this and not look at implementing for 2022 due to the time needed to communicate and educate members around this program. And then the last one is Kaya Health, which is kind of a digital health, well, it is a digital health point solution for musculoskeletal problems. So basically, it's kind of a somewhat virtual physical therapy. I hinder on using the words physical therapy because it's more preventative than it is actual post. And so what this is it helps members, if you have some kind of back problem or something, it will, give you stretching techniques to kind of help subdue those pains. And so again, it's more preventative than it is anything. And so there is actually some fees for this. So it's an initial $200 per user per month for the first 3 months, and then $20 therefore after. And I believe it's a 12-month program. So then after that, the fees would then start again if a member were to go through another series. And so Mercer kind of recommends considering implementing this because, we've seen with these digital health point solutions, especially in COVID, there's been quite a bit of an uptake because people don't necessarily want to go into the doctor or go to physical therapy at this time. And again, also it expands coverage for those in more rural areas. So that kind of lists out Providence's recommended changes. I know I kind of went through those fast. Does anyone have any questions?
And again, no board action required at this point. So these are all our preliminary recommendations. EviCore is our, as Mitch mentioned, it's sort of our annual look at EviCore, and often we have not, at least Providence is not confident on that piece that it would be a smooth, seamless sort of implementation for PEBB. And Ali could probably talk about some of the pain that OEB has gone through with EviCore, but this might be one that we permanently table until possible the savings are needed, because it does come with savings, right? I mean, if you do enhanced utilization management, there are savings, but just the member feedback might not be worth those savings. Okay. All right, so moving on to MODA. So there's a lot to look at on this slide, but MODA has a few different components to their renewal that are worth looking at. So on the left-hand side of the page, we have their base administrative fee. So this is the fee that we outlined in the previous table of increasing 2.9% compared to 2021. You can see that all the various components are increasing at various the same rates. We don't have any situation with MODA that we did on Providence with some different things happening or different changes happening within the fee itself. MODA is pretty straightforward. So their overall fee again is increasing from $78.32 to $80.63 per employee per month. On the right-hand side of the page is the new program, MODA 360, that was implemented effective 1/1/2021 for PEBB, and also it's in place for OEB as well. But for PEBB, the fixed components are listed on the top table, and then the variable fees, which are based on participation within those specific programs, are listed in that bottom right table. So MODA 360, the fixed costs, which are charged to all MODA enrollees, total $4.38. And for 2022, they're proposing an increase of 3% to $4.51. The variable fees, based on actual participation within these various programs, are staying the same. So those are not increasing at all. And what those fees come through are basically claims on the claims wire. So if a member within MODA uses the diabetes program through Livongo, for instance, MODA will just pass that cost on within the claims itself, rather than charging a separate per employee per month fee to administer that part of the program. So from Mercer's perspective, we like actually, I think, Siobhan, you mentioned the variable, the fee analysis we did last month, and we talked about variable fees and how we generally don't like them. Well, on these type of programs where it's based on utilization within the program itself, we actually do prefer some of these, just because, again, that way you're only paying for the members that utilize the program versus everyone enrolled within the plan. So we prefer to sort of see these, it's good that these are staying the same, but again, we have more questions for MODA on the other components. So like Providence, MODA has a few larger changes that we'd like that we're looking at, and we don't have a lot of information right now, but we can give the board some background on what's happening with the MODA's pharmacy benefit manager. So for everyone's background, MODA's pharmacy program or PEBB's pharmacy program through MODA is with the OPDP, so the Oregon Prescription Drug Program, which is part of the Northwest Prescription Drug Consortium. They offer pharmacy benefit administration services, for which MODA is the administrator of that program. MODA, as part of that, provides most of what any of us kind of care about on the front end as we may be users. So they do the account support, clinical services, benefit design. So all of these programs, Mitch mentioned the Specialty Light program, for instance. All of the clinical aspects of the pharmacy program are managed by MODA, and MODA is helping to control the costs. but they contract out with a PBM. Currently, it's a PBM called Med Impact. They're switching effective 1/1/2022 to a PBM called Navitus. And what the PBM does is it actually manages sort of the underlying claims processing. It manages the pharmacy network contracting, rebates, all of that kind of stuff, all of the underpinnings of the program, whereas MODA administers all sort of the clinical and account management services. So as part of the new contract that MODA has with the consortium and OPDP, they actually have the new partner with Navitus Health Solutions, effective 1/1/2022. So that PBM relationship is going to be changing from Med Impact over to Navitus. So what MODA is doing on PEB and OEB's behalf is looking at member disruption and financial implications for this change. Member disruption, at least initial member disruption, will be available in Q2 of this upcoming year, so April through June timeframe. Final analysis for member disruption will actually be completed later in the year in the October timeframe. What they typically do is look at a prelim look at what disruption what disruption will look like. But as we know, drugs change throughout the year. New members may be disrupted and whatnot. So the final mailing list and changes will actually go out in the October timeframe. So we're working with MODA on behalf of PEB to look at not only the member aspect of this, but also the financial implications. So similar to what Providence has with the Cigna piece, if there's any savings to be had from this, we will price it into our underwriting for the upcoming year.
Mitch, this is Ollie. We're actually planning on bringing in the director of OPDP to kind of give the board an update on that transition, probably around May timeframe, and just some of the potential for disruption.
Okay, Mitch.
So this slide's kind of looking at MODA 360, which is their concierge-like service that they started offering 1/1/2021. So this is kind of the first couple bullets, kind of just describe what it is. But again, it just helps members navigate the healthcare system and better support for members as well. It also incorporates some of the 3 digital health point solutions that we've been talking about along the way. So Livongo, diabetes management, Maru, which is behavioral health, and then Sirius MD, which is their new text-based point solution. And then on the next slide, this kind of goes into more information about enhancement considerations within MODA 360. So for 2022, MODA has kind of proposed a dental integration piece. So this will not only be just for medical members, it'll be for dental members as well who are on the MODA medical plan. And so what it tries to do is bridge and close gaps in care and identify members without recent dental claims to kind of push them to go get their preventative visits. So the cost on this is 46 cents PEPM, so per employee per month, on the medical members, not the dental. And then underneath that is advanced image steering. So think CTs, X-rays, MRIs. And so what this tries to do is push members to alternative lower cost facilities, and kind of there would be savings there. The program would be voluntary for members, but right now it is a pilot program focused on steerage from a few high cost facilities. Right now, since it's still fairly new, there's no cost impact. So that would probably be hard to tell because it hasn't been so fairly new. And then
hey, I just wanted to jump in. Sorry, I was processing this dental integration. So it only applies to people who also have Delta Dental, but that per employee per month is for everybody, whether they have Delta Dental or not.
So yeah, so that's a good
Okay.
point, Siobhan. It would be on the 6,000 members enrolled in medical. So you could have Moda Medical and probably Willamette Dental, but there would still be a 46-cent PEPM.
But the program only helps those on Delta Dental.
Correct.
Okay.
And then the last two, so right now, Moda is kind of evaluating vendors for these last two, but the first one is chronic kidney disease management. And so what this essentially is aimed to do is use preventative analytics to identify members who may need intervention, and also educate on decision making, and partnering with their primary care. The last one is an enhanced musculoskeletal program. And so this would ideally be something kind of like the Kaya Health on Providence. So Moda right now is evaluating members to kind of fill this digital health point solution hole for musculoskeletal programs. And so that kind of wraps up the Moda 360 enhancements. On the next slide, they have other recommendations. And so, again, no board action is required at this time. We'll provide final recommendations in meetings to come. But the first one is going to be cost sharing for generics and preferred medications. So this would then change some things. So it would incentivize the use of generics or biosimilars, and by changing the generic retail cost share to $10. So this would be a slight increase of 0.01%. And then underneath that is emerging cellular and gene therapies. And Moda's still kind of working on this one, but it's pursuing the opportunity to establish COEs for gene therapies to hospitals. And this right now is kind of adopting the language in the handbooks to allow steerage for COEs. Again, currently there's just no cost impact as they're still exploring this. The third one down is coordination for specialty programs for behavioral health. So this is kind of covering services that generally wouldn't have been covered by commercial insurance plans. Especially now, I think, in a lot of our clients, we've seen an uptick in behavioral health, especially due to the pandemic. So this would kind of expand that coverage for those kind of items listed there that typically aren't covered. And there is kind of a small increase into this since you are making your benefits richer.
And I would just add, Mitch, on this coordinated specialty programs for the behavioral health, these are items that actually Medicaid would typically cover. So Moda indicated that on the Oregon Health Plan, a lot of these are actually already covered. So we thought this was kind of an interesting approach and looking at some of these social determinants of health type activities that Moda is offering, Moda is trying to work on behalf of the PEBB population. So it does have a small, impact because you're covering more services. But in reality, I think this would align with PEBB's vision and OHA's vision to address some of these underlying social determinants of health, especially as we get into, the mental health and behavioral health issues for children and young adults. So again, even though it's sort of a cost impact, these are what they're kind of doing on the Medicaid side. So we thought it was an interesting proposal.
Yeah, good point, Nick. And it's kind of the same with the last one, disease management programs to treat pain. So then this is kind of, more pain management and opioid addiction. So again, those underlying social determinants of health. And again, this is a small increase as well.
This is Siobhan. I just want to appreciate you bringing these up so we can consider them.
Yeah, I think overall, all of these, even though they have a cost increase to PEB, I think they align with what we're trying to do on behalf of the membership, and they're very insignificant, obviously, as far as the cost impact goes. So again, I know no board action, or this is all preliminary, but I think ultimately we'll probably be recommending adopting these changes. So. Okay. All right. Kimberly, can you remind me, we have until 11:30, right?
So you
Or
have
11:20.
So technically you have until 11:40 and then we go on break.
Okay.
So I don't know what this next 2C, you're good at this time.
Okay. Thank you. All right. And I know people are probably ready and willing to get on break here pretty soon, so we'll try to hurry it up. So Kaiser, the last medical carrier we want to look at is Kaiser. They're proposing a 2.72 increase to the premium rates. This is they'll finalize their renewal in the March timeframe, and we'll update the board once we have the final rates. But we wanted to call out two interesting enhancements that they're making to their program. Virtual care enhancements. So Kaiser already has a strong virtual care offering to begin with. They're adding some physical therapy options through a partnership with MedBridge. One of the things that I thought was cool or interesting was this new virtual OB care for low risk pregnancies. Considering my wife and I just went through this last year, I thought this was interesting take and a really member-centric type benefit. But basically what Kaiser is going to do is provide blood pressure cuffs, digital scale, and a Doppler to listen to the baby's heartbeat. So again, sort of transitioning from in-person care to as much virtual care as possible, just for the safety of members. This will allow the expansion of that care through pregnancy to expand actually into the third trimester. So we're trying to limit and quite frankly, even for convenience factor outside of the safety factors. So on the right-hand side of the page is the mental health and emotional wellness tools for first responders. So Kaiser's rolling out some new enhancements for specifically targeting first responders. So police, firefighter, ambulance. They have some resources and support within their My Strength app. Basically trying to reduce stigma, address burnout within those professions, messaging and interventions, and video interviews with other first responders. So just getting kind of, again, similar feedback from people who may be in your similar shoes and going through similar stressors in life. I thought that was kind of an interesting new benefit that they're working on. And then finally, for Kaiser in Southwest Washington, they are partnering with Peace Health Southwest effective July 2021. So this upcoming summer, Peace Health will become an in-network hospital for Kaiser Permanente members starting in July. Legacy Salmon Creek, who is the current sort of partnership in Southwest Washington, will still remain part of the Permanente network for emergency and obstetric services, but other services will transition to Peace Health. And PEBB has approximately 800 members in Clark County who would likely be affected by this change.
Nick, I just had a quick question. The 2.72% is for both the deductible plan and the HMO plan. Is that right?
That is right. Yep.
And then I know you're highlighting enhancements. Are they saying things like moving to virtual physical therapy and the virtual OB care, which both sound great, but that costs more? Is that the implication here?
No, Siobhan.
Okay.
Both of these are trying to reduce costs, but the overall premium, I guess the top half of the page is just the overall premium impact, just forecasting claims out into the future. The second half are just some enhancements they're making, not necessarily that these enhancements are going to increase cost.
Okay, so we'd get further into why the cost increases then.
Yes.
Okay, thanks.
Absolutely. Yeah, and Kaiser is always good about sending the underwriting. Like Mercer, they're making adjustments to the underlying claims data and projecting that forward. So we're all sort of following a similar path to getting to the 2022 projections for both the self-funded plans and what Kaiser's doing on the fully insured side of things. But we'll, basically we still have to dive more into it. And in a few months, we'll have their final renewal. Okay. All right, Mitch, you want to take us home with the non-medical?
Yeah, so this last section is going to be our non-medical renewals. So you can see on slide 31, this is pretty straightforward. The 1.5% increase to the dental administration fees. So there's no change in the oral wellness. All of it is going to be on the pure admin fee. And then below, there's really no other update other than the MOTA 360 addition to dental. And again, the 46 PEPM on the medical plan members. On the next slide, takes a minute to change, I guess. This is looking at the Willamette dental renewal. So again, 0% increase, so pretty good news. And we wanted to call out a couple two things on the bottom here. So as we saw, like in those beginning slides, utilization in dental dropped significantly in that March-April timeframe. So Willamette has kind of come out this deal to waive the $10 office visit for new patient appointments in the next plan year. So essentially, if you hadn't seen a dentist before, you would just be waived your copay. And again, it's to incentivize members to start coming into the office versus skipping their appointments. And then over there on the right is kind of just looking at some prior benefit changes. So this is looking at changing in 2020, we changed the implants to be covered under the annual max versus the copay. And so far last year, only 61 members used this new benefit. And then 24 were still grandfathered under the copay plan. Any questions on that one, or even the $10 visit office copay? Okay, so then moving on to Kaiser again. So more good news, 0% increase. And again, we're still working with Kaiser to finalize the renewals, which will be for the coming board meetings. And then in that bottom half is some program enhancements we just wanted to call out. So Kaiser has started this virtual dentistry effective March of 2020 of last year. So kind of interesting, virtual dentistry. It's kind of more of a hotline, I guess, to help kind of ease comfort when you're experiencing some discomfort with dental. And members can reach out via phone, email, and they also do orthodontic video visits, which can kind of help members if they're experiencing something with their braces or Invisalign and they just want to double check versus going into a full office visit. Underneath that is the risk hygiene treatment, which kind of creates a plan-specific outreach to each member on when they should get their cleaning visit scheduled. So it's kind of helping to close gaps in care and more customize the benefit towards each individual. And then again, underneath, keep going, Kaiser has implemented some operational improvements, including some more dental urgent care facilities, and then expanded their operation hours and started giving flu vaccines at the Grand and Eastmoreland dental offices. And then that final bullet, future enhancements. So again, looking more digitally, more text and email notification for scheduling, kiosk check-ins, and more online options for members to schedule their appointments. So,
We received confirmation from Kaiser that they are not shipping pliers to members' houses to work on their teeth. So if any board member was worried about that, that is not the case for virtual dentistry.
I was wondering how they were going to tell if you flossed, if they saw any bleeding of the gums, so they could get after you if you hadn't flossed enough, you know, through that definitely you wouldn't want your camera on, right?
Right.
Or like a string that you tie your tooth to the door, anything like that. Yeah.
Exactly.
Just checking.
We didn't check with that one, Sean. We'll get
well,
confirmation. Yeah.
Those strings can get really expensive, because they're not ordinary strings.
Right.
They're special medical strings. So.
Yep.
You gotta watch out.
And then kind of rounding out the non-medical renewals. So VSP, the vision plan, is a 0% increase on administrative fees for 2020. 2022, sorry, kind of weird to think about 2022. And then we have a note underneath that your admin fee has been $119 since 2017. And then one call out we had was vision therapy. So I think this has been asked about in previous years. So we kind of got a cost impact here. So what vision therapy is it's a therapy or training to kind of help the following conditions like turned eye, eye taming, lazy eye, focusing, kind of just general eye movements. And so what the coverage includes is an $85 examination. So up to $85 is covered for the examination, and then up to $750 is covered for the actual treatment or therapy sessions annually. So the overall cost impact is 1.8% or about $200,000 annually.
Yeah, and I think to Mitch's point, we've had some members bring this up that it would be a benefit for PEBB. So we've asked VSB to sort of provide the overview and the pricing.
So this is an interesting, this vision therapy, we've actually had employees in corrections that have had, it seems to be like there's almost like teenagers, there's this weird gap in time where the parents have had to just try to decide, this is so expensive, but my kids' eyes and their school, obviously this was pre-COVID, where now we're all watching the screen all day, but it's the first time I'd heard of it, and they were definitely trying to figure out how to afford, because it is very expensive.
Mm-hmm. So depending on where we land within the composite rate, obviously this could be a consideration enhancement for your members.
And that 1.8% is just on the vision service. That's not on the overall composite rate.
That's exactly right, Siobhan. Yep.
And this kind of treatment is not standard. I guess that's a little, I'm surprised by that because it seems like it would be.
Yeah, and I think it's considered above and beyond normal eye treatment, and that's why it's not standard. Yeah.
And is that true for your general book of business? Like most eye coverage does not include these kinds of therapies as basic part of the general coverage? Is that what you find?
Yeah, Sean, this is the first time that vision therapy has been even discussed on my other compared to my other clients.
Interesting.
Yeah.
Okay.
What we can do is get some information from VSP. I think it would be helpful to have book of business data from them on how many of their clients actually cover this benefit, and if this is any sort of, if this is a middle ground benefit, or if this is kind of you take it or leave it type offering from VSP, or if they have different options that the board can choose from. Just some additional background I think would be helpful.
I think that'd be great.
Yeah, I'm discovering how much I didn't know about my vision therapy. All right. Thank you.
Yeah, this is Kate Nass also. I totally agree. This is new to me, and I'm with Sean. I feel like this is something that I kind of thought would have been covered, so it surprises me that it's not. So I think just knowing a little bit more would be great.
Yeah. Sean, renewals are always a learning session for all the things. Sorry, I cut someone off.
Oh, that was me. I just wanted to jump in. I know you're going to talk about next steps, and this is just the renewals on what we have with some suggestions of enhancements. And I'm wondering if in the next session we're going to return to some of the other enhancements we were considering, like the WPATH recommendations for transgender services. We've also had past conversations around fertility services and looking at that. So just wondering when that's going to come up again.
Look at that, Siobhan.
Yep, yeah, exactly. So the fertility is on our radar, and that is now going to be in the March meeting. And so we're working with actually Ollie and Cindy within OHA to receive some member testimonials on the fertility benefit, because I know this is an issue that is top of mind for quite a lot of your members. So we're going to look at the fertility benefit in the March timeframe. The transgender, the WPATH standards of care, we have a separate conversation with Providence, Moda, and Kaiser happening with Michael Garrett, who's sort of leading that charge. So we're actually taking that, Siobhan, outside of just a normal renewal work stream, which is why we're not talking about it in this presentation, because some of those definitional changes can happen outside of the normal, 1/1/2022 renewal. So we're doing that outside of the renewal process. But I think once we have sort of updates on that particular work stream, we can absolutely share it with the board.
Great, thanks.
Yep. So again, March is the big fertility and inclusive family planning benefit month. So as part of that meeting, we'll come with the estimated cost impact for a number of different for different options for PEBB to consider. Ultimately, I don't think we'll need a board decision on yay or nay, because we'll still be waiting on final, rates from all the carriers and final self-insured rates. But I think directionally what we'll want to do in March is just say, okay, from the board's perspective, let's narrow down what we want to consider for 2022. So that will be the goal for the March meeting. But we'll have the member testimonials as part of that as well. And then we'll have further information on some of these changes from Providence and Moda on their two sort of big changes that each of them is going through right now. And that concludes our Mercer presentation. Any questions or comments?
So I have a general comment, and I feel like the main thing that I took away from my experience on the board with Representative Greenlick is this, which is to always be vigilant or curious about items that plans should already be doing that then they want to charge money for, around like good coordination of care, etc. And so I don't have a particular thing that I'm like, oh, that one. But I'm asking Mercer, I guess, to just like when you're, going to round 2, that you have a particular focus, almost obsession that he had with that particular point, because it was like, that was basically, if I could boil down his, most of his questions, it was basically that question. It was like, why are we being asked to pay for this? That is coordination of care. That's their job. And so, so that's just a theme, I guess, I'm asking for Mercer, just kind of like, have your eye on, and to take a second pass at that kind of question whenever there are proposals. That being said, like, we are clearly discussing things that are new in some situations, where like adding a benefit. I mean, that makes sense. But so it's kind of a balanced thing. But just kind of want to put that out there.
I think you're absolutely right, Sean. I think there's a line between, to your point, adding a benefit which we know will impact claims costs versus being charged more for just because it's 1/1/2022 and we get to charge a different fee. So again, one of the things that I had in mind was requesting of the carriers what is different about 2022 that, essentially, to your and Siobhan's point, justification. For the fee increases and some of the stuff that I think I know what you're talking about, some of the coordination of care type stuff that theoretically should already be happening. So again, yeah, point taken.
Thank you.
Yeah.
All right, well, we're going to take a 10-minute break, and so we are going to start back up at 11:56. Do not log off. Just you can turn your cameras off and get yourself 10 minutes of stretching, and we will be back on deck at, well, now it just flipped to 11:47, so 11:57 back on deck. Thank you. Jeremy?
Hey.
Were you able to make it back? Oh, good.
I am sorry I got delayed a little longer than I thought I was going to.
Oh, no, you're fine. You're fine. We've got one more minute to our break. I just wanted to make sure you were able to make it back. Good morning.
Yeah, morning. Well, for 3 more minutes anyway.
Yeah, I'm going to take every second I can for the morning, you know. All right, looks like we're at 11:57, and we'll go ahead and get started again. Hi, Ali. Okay, so this is the PEBB board meeting, and we're back from break. And next up will be Senate 889 update, and we've got Jeremy Vandehey here with us, the director from OHA. So good morning, and thank you, Jeremy, for joining us.
Great, thanks. So just a quick update on Senate Bill 889, which is will establish a statewide cost growth target. 2 kind of major buckets of work. One is getting that program launched now, and then a parallel body of work that has spun out of it, which is really around more rapidly advancing payment reform and moving from fee-for-service to value-based payment. So I'll give an update on both of those. First on implementation generally. We've finalized the report, and all the recommendations for how the program will operate has gone into the legislature. The implementation committee we originally thought was going to be slated to end at the end of the year, but they're going to stick around for another year as we get into implementation. So we've got the same group of folks that have made the recommendations for the program, and we can keep bringing just kind of implementation status updates, and there's a few other things we want to continue to work through with them, and we expect that eventually they'll be replaced with a kind of ongoing healthcare cost committee of the Health Policy Board that will be helping manage the program and helping provide advice on what's driving healthcare costs more broadly. So that group will live on there. So they'll be starting to move into some more of the implementation work this year, and we'll start getting into more implementation generally around what data is going to be needed from payers and how that will be submitted, and data specs and things of that nature. Part of one of those ongoing conversations I think we'll want to be having with PEBB and OEB teams is really how does this program complement the types of analysis that are done by the consultants for PEBB and OEB. What we really want is sort of a two-way street in terms of information sharing of what are we seeing on a statewide basis of driving costs, what are we seeing in individual programs, and make sure that at the end of the day, this program is kind of helping bridge a lot of the conversations that right now happen in silos between Medicaid, PEBB, OEB, and the commercial market around where the cost challenges are. So it'll be a busy year of implementation. 2021 is the first year that the cost growth target applies. We won't know until towards the end of 2022 how we did. So we've kind of got some space now to be working on implementation. The only piece that needed to go back for legislative approval was the accountability piece. So what happens if an insurer or provider organization is not meeting the cost growth target? The recommendation from the committee was that we have kind of a phased in of accountability, that because we're in a pandemic and it's a new program, the first year there would only be transparency. So we would be naming insurers and providers who didn't meet the target, or either way, they were above or below the target. But there wouldn't be anything beyond that. But then the next couple of years after that, there would be performance improvement plans. And then starting in 2026, there would be an escalating, a variable financial penalty for an organization that's above the target. And so that will phase in over time, and we hope that it's not a tool we ever actually need to use, but the idea is to just make sure that everybody's taking this seriously. So that requires an additional bill to pass in order to implement the accountability piece. So that's being considered by the legislature right now. It's in House Bill 2081. There was a public hearing on it last week. And just waiting for the work session at this point. Separate from launching the cost growth target, the implementation committee for the program recommended that we have some targets that would apply statewide, and that we really try to get payers and providers across the major markets to agree to really advancing value-based payment over the next several years, very much aligned with where the PEBB and OEB boards have been and where we've been as a board in terms of setting targets for out to 2024. And they recommended that we sign it. We try to get the major payers and providers to sign a voluntary compact to make their best effort to try to hit those targets. That compact is now out on the streets. We've gotten a commitment from all of the major insurers in the state, from several of the larger health systems and provider organizations, and we have sent them the actual compact out about a week ago, and are getting the signatures back on that. So we've got signatures from all the state lines of business, so from OHA, DCBS, PEBB, and OEB. We've gotten signatures back from a couple of the hospitals, including Samaritan, and as well as some of a couple of the health plans, Pacific Source and Providence. But we've gotten much more commitments than that, so we're just waiting. The ice storm last week kind of screwed things up for getting electronic signatures when people didn't have electricity. So hopefully those will start to trail in this week, and we're hoping that by the end of this week we'll have a pretty good share of the market that has signed that compact. The next step after that will be a technical group that's going to get off the ground, that will be a mix of providers and payers, that will be kind of a coordinating body to really help try to problem solve and help align this work across markets. The idea being that a lot of the challenges we expect we'll face will not be specific to single markets like PEBB or OEB or Medicaid. And so really want to think about how we problem solve this transition from fee for service to value-based payment more broadly, where applicable. So there are some state seats on that, and we'll probably be back in touch to see who makes sense from the PEBB and OEB boards to sit on that group. So that's our update right now. Things are moving along. Happy to take any questions.
Oh, they're letting you off very easy, aren't they? Thank you so much for the updates. And so how many people are actually on your committee that's working on the Senate Bill 889?
So the implementation committee itself is 18 folks. We're looking to add a couple of additions to that, and that's sitting with the governor's office right now for the thumbs up, but looking for adding a couple of mid-sized clinics. That's been one gap that we've noticed on the group. But yeah, so it's a good sized group. And then the work group that will work on value-based payment, I think we have that slated as about 12 folks, but my memory might be shy or might be wrong there.
Thank you. I was hoping it was a diverse group. Okay. All right. Well, thank you, Jeremy. And now we're going to go on to legislative updates, and Glenn should be joining us.
Really, I can kick us off until Glenn joins, so I'll let him talk about the bills. But just to give a quick update on our Ways and Means presentation that you were obviously a big part of. You and I and the OEB board chair, Jeff Brown, presented 2 Ways and Means about 3 weeks ago now. And just wanted to give an update to the board. It went very well. Jeremy was actually in that session as well, presenting on health policy and analytics. But the only takeaway we had was to come back, and I actually met with Representative Nose last week to talk about the 3.4%, and he was really curious how that's going and some of the issues with the 3.4%, like having a 0.8% renewal last year kind of resets the baseline downward and kind of sets you up for a more challenging test the next year, and talk about some future alternatives to look at. So that was a really good discussion, but overall I thought it went really well. I don't know what your impression was, Kimberly, but
I thought it went well too. I was impressed that all of us Jeremy, Patrick, Allen, all of us got in under what the wire, weren't we, like a minute to spare or something? We got her done. That was a lot of slides and there were some questions. So, you know, it worked out well.
Yeah. All right, Glenn, did you make it on? Nervous about Glenn. He had some pretty severe power issues, so I might need to follow up with him, and he can maybe finish this off or send out an informational handout, if that's all right, Kimberly.
Yes, that'll work.
Okay.
Can you hear me?
Yeah, it sounds like Glenn, there's some. Go ahead and speak again, see if that feedback goes away.
Can you hear me?
Yeah, but it sounds like you're in the Grand Canyon. How about we go back to Glenn later, Kimberly? Does that work?
That will work, absolutely. All right. So next up is Innovation Workgroup update, and Sean, you're up.
Yeah. So so the Innovation Workgroup meets again today in the afternoon. Up on the agenda, what we've really been up to is discussing Centers for Excellence and an RFI related to that to gather information from the field about, yeah, I mean, that idea I know that we've kicked around a few times as a board. This feels like a kind of mid-range strategy for us that's potentially coming to fruition. So, you know, we, you know, asked our current carriers and also some other organizations, some of which are out of the state. We seem to be, well, I'll just leave it at that for the moment. So more discussion about that today at the Innovation Work Group. We've also been talking about, you know, kind of following on the present, you know, Jeremy's update. We've been talking about moving forward. What does it look like to move forward with, you know, value-based payments, that sort of thing, and moving forward those ideas. So we should be pretty quick soon here coming to OEB and PEBB boards with some specific results and proposals from what the Innovation Workgroup has been up to. Ollie, is there any more specifics you would add here at this moment?
I think Margaret's on, actually. Maybe she could talk about the performance metrics.
Yeah, sure. Just to chime in with a quick overview, I think Sean introduced a couple of concepts that are kind of big ones the work group has been looking at. There are really, I guess I would categorize, I think, three main bodies of work that are kind of queued up for the work group the first half of this calendar year. The first one being the Centers of Excellence program investigation that Sean mentioned. We actually, in partnership with PEBB and OEB consultants, are working on this and did release an RFI late last year to capture just general information from providers that offer Centers of Excellence programs, specifically focused on musculoskeletal conditions. So we're going to be doing some further review of the information we collected and ultimately deciding, I think that the decision before the integration work group will be whether or not to recommend PEBB and OEB move forward with pursuing a formal program around musculoskeletal centers of excellence. And if the consensus is to move forward with developing that sort of a program, that's probably about a 12-month or so undertaking to get the program design established and pulled together and off the ground. So more updates to be coming about that. A second big area of work that the Innovation Work Group is going to be kicking off actually in their meeting later today is going to be around performance guarantees in PEBB and OEB contracts. For a number of years, PEBB and OEB have both had different categories of performance metrics included in contract with fees at risk applied to certain measures. And as we're rolling through our plan renewals now for the next benefit plan year for both PEBB and OEB, this is just a very timely opportunity to step back, take a look when we think about measurement year 2022, which will start January 1st, what specific measures of performance and what dollars at risk for meeting performance targets do we want to have in both PEBB and OEB contracts. And so that work is going to be going on for the next couple of months in the Innovation Work Group to scope that out to ensure that we have as I said, both PEBB and OEB contracts currently include these provisions, but it's more about looking at refining what's in there currently and making sure we're aligned across both programs. We're closely aligned, but I think there's some opportunities for further alignment and refinement of what we've been doing. So that's kind of a second major area of work the Innovation Work Group will be working on for the first half of this year. And then lastly, as Sean mentioned, doing a lot of work around looking at approaches to increasing value-based payments. And the work group is, again, working in partnership with PEBB and OEB consultants, looking at releasing another RFI this spring to providers, specifically to capture information related to plan design approaches. And it sounded like, did I cut someone off? Maybe someone wanted to chime in.
Hello?
Oh, that might, yeah, hello.
Can you hear me?
Okay. Yes, yeah.
Hello?
Yeah,
okay,
hi.
Go ahead.
Okay, well, so just to briefly summarize, so that additional work to capture RFI responses related to plan design approaches that incorporate value-based payment arrangements is something we're further developing, and expect that by late spring or early summer, we're going to, the Innovation Work Group will have some additional updates and information to bring forward to the board about that. And that is all I have, so I'll stop. Any questions?
Thank you, Margaret.
Of course.
Okay, well, I think Glenn has joined us now, and he was going to give us some legislative updates. Ali, should I just let him now that he's...
You bet. Go ahead, Glenn.
Well, we might have lost him again. Did we have any public comment?
Rose. Yeah, I think Rose spoke, but didn't quite get you, Rose. Any public comment?
Hey, Ali. This is Glenn.
Hey, Glenn.
This is Glenn. Sorry about that. I was having a bit of computer problems this morning. I give just a quick update on the legislation. I will focus, well, first of all, everyone knows that they're in session right now. They're gone into a number of public meetings. They have about till mid-March to get bills through policy. I'm just going to focus on some of our priority one bills. First of all, Senate Bill 12. This is a bill that requires PEBB and OEB to have a program whereby we literally will pay for people to travel and pay for certain medications that they can actually get overseas through, they go actually to Tijuana or to Vancouver. It's based on a program out of the state of Utah. We did an analysis on that. It really only, if you use the same drugs that Utah is using and the same amount of participation, would only save about $500,000 a year on drug costs for PEBB and OEB, which are run into the 70 millions. It also has a number of legal problems to it. It stretches the concept of the FDA's what's called personal use. And then it also probably wouldn't be tax deductible. And then there's a number of implementation concerns. But I did want to focus on also based on what Jeremy had talked about, House Bill 3044 and also 3047 would actually require that every one of the insurers and health service contractors who contract with PEBB and OEB would have to sign the compact that he was describing. It's a bill that could create some issues in regards to that if one of our major insurers pulled out, decided not to contract with us because of that reason, then we would have to go in, unless we could fulfill it with one of our existing insurers, we would have to go into a medical RFP, which usually takes around 18 to almost 36 months to develop and implement. The last one is House Bill 2810, which Ali has been has had meetings with the Representative Dexter, which wants to require that we implement CCO-like plans. There's a number of requirements such as global budgeting, value-based payments, and by 2023 for at least one, each of our carriers would have to have one version, and then by 2026, everyone. But there's also, and Ali could give a little bit more, they actually now got down to where they want to do almost like a regional, maybe like a pilot program. It hasn't gotten a hearing yet, so I don't know what its future is. But Ali, did you want to add anything more on that?
No, I don't think so. I think you covered it quite well.
Okay. Those are pretty much, we also just yesterday, a bill was launched that put on a public option to the marketplace. The way that might affect us is it, again, would require that our insurers and the providers who deal with PEBB and OEB would have to participate in this public option plan or offer one of them. That's kind of what I wanted to go over in a short time period. Did anyone have any specific questions about any of these bills? Those are just our top priority. We're doing also about around 30 some that are really what we call a priority 2 or 3, meaning it usually is the case where it's adding a new benefit or it's changing costs in some way on the market.
Glenn, I don't know if it's really worth getting into the details at this point. So if you have more, let me know if it's not worth it. But I'm just sort of confused by the concept of Senate Bill 650. Like PEB, like it seems like this would be for OEB, not PEB.
Yeah, no, and that's fine. I can get into that. We've done, for all these bills, of course, we've done a bill analysis that goes to Jeremy and then to others at OHA. But I think that's a drafting error. I think they meant PERS.
Okay.
You know, and that's what we pointed out to them, that PEB doesn't have a relationship with the school districts, doesn't collect data on unfunded liability. I mean, OEB doesn't collect that data either.
Right.
Unfunded liability actually through the school districts is pension unfunded liability has to do with PERS.
Okay.
And then you think.
Okay.
That was a really good question, Sean.
It's an error. Okay. Well, Well, that makes a lot more sense because I was like, what do we have to do with school pension? Okay.
No,
Fair enough.
yeah, I saw that when it first came out, and I'm like saying to the government relations folks, that's
I
not
guess,
us.
yeah,
That's PERS.
I guess we're related in that we're government, I guess. But
No,
the
I think
the similarity
it was
ends
a draft.
there.
Yeah, I think it was just a drafting error that
Okay.
they put
All right.
PERS instead of PEBB.
All right. Okay.
That bill, it's going to go to Finance and Revenue and then requires a 3/5 majority. There's not been any movement on that bill so far. It's a bill to create public assistance. It's based on what's called the Employer Responsibility Assessment, where you would actually assess businesses, and then the funds would go to different programs from, I believe, OEP, some of the others. So whether it gets any traction, I don't know, because it like I said, hasn't even gotten a public hearing yet.
Glenn, Mark Perlman has a question.
Sure.
Hi, Glenn. I'm wondering if you know anything about SB 551 about part-time faculty.
Yes, yeah, that's actually OEB.
Pardon?
I'm sorry, yes, I do. That Senate Bill 551 is currently, OEB runs a program called the HB 2557 program that allows part-time faculty who meet a certain amount of hours under PERS to participate in 4 different health plans through OEB at a self-pay basis. What this bill does is, and actually this is the 3rd year where they've tried this, is they want to have the state pay 90% of the monthly premiums and the member pay 10%. It has an extremely high price tag, up to about $40 million for the 2 bienniums. And most of this is the general fund that would be required to cover the state's 90%.
But I'm confused because my understanding is that part-time faculty who are eligible for benefits right now only pay 5%.
I'm not sure what you mean. Underneath,
yeah,
what
these
are.
Go ahead, Glenn.
No, these are folks that are not getting any coverage through their university or college. These are part-time who are either don't meet the classification underneath the ACA rules to be covered by their college or university, or well, I mean, in that case, and then if they don't, and they meet these 600 hours under PERS, a system that we really set up with PERS, if they are not eligible through that, then they are eligible to participate at a self-pay basis through this OEB program. It really was, it's a bill that started off in 2010 as an attempt to really address the problem of part-time faculty not being eligible for benefits, and the really expanded use of part-time faculty at the colleges and universities. And then it wanted to create some way, some method whereby the state could assess people who are working at multiple institutions and meet a certain level that would then make them eligible for this program established through OEB.
Oh, I see. So this won't increase because lots of part-time faculty are already covered under PEBB if they work more than half time at one institution.
Yes. No, these are people below that.
Oh, I see. Okay.
These are people who have not qualified for PEBB coverage or OEB coverage.
So people that are teaching, say, quarter time at 2 or 3 different schools, but not eligible under any of them. I see.
Yes, exactly.
Okay, thank you.
No, it's kind of a confusing, and it's basically when we do this eligibility process, we check to see, are they already covered underneath OEB or PEBB? And then we also check with the institutions to find out, did they work there, a certain amount of time. So, I mean, these are people who are not basically eligible for their college or university.
It's a very manual process we do every year to find these individuals.
All right. Well, thank you, Glenn. We appreciate you connecting with us today and updating us. And I think did we finally actually hear Rose? Do we have any public comment?
We do not.
Okay. Okay. Is there anything for the good of the order for the PEB board of the February meeting? All right. Looks like we're going to call this meeting adjourned at 12:27. Thank you all for joining us.